So greetings everyone, and thank you for joining us for another Eye on Africa. I'm Awasar, Assistant Director for Academic Affairs at the African Studies Center at MSU. And Eye on Africa is our weekly seminar series that we have every Thursday at noon. So we organized today's lecture in collaboration with the Department of Psychiatry. And I'm going to pass the floor to Professor Michael Boyven, who is the director of the Psychiatry Research Program, to introduce our guests. So Michael, I'm giving it to you. I think you're muted.
Dr. Marcel Yotebeing is Associate Professor of General Internal Medicine at the Albert Einstein College of Medicine, Shiva University in the Bronx, New York. But I first met him some years back when he was still at the Ohio State University and one of the best funded NIH-sponsored researchers working in Africa. That was at the Ohio State at that time. I got to know him because of his work in the area of the epidemiology of HIV disease, both mother and child. And he's still at this point also leads one of the major NIH-sponsored center programs involving numerous clinics across both Kinshasa within the Democratic Republic of Congo, as well as Kigali in Rwanda, two very challenging places to work, and yet Dr. Yotebeing has become extremely prominent within that work in Africa. He's going to share a lot about that work today, so you'll get a chance to see some of the best of what this area of neuropsychiatric epidemiology has to offer in the area of infectious diseases in Africa. I want to welcome the psychiatry residents in attendance and make sure you get credit for your attendance from Kelsey, and also any psychiatry faculty. You're very welcome as well. I really I'm pleased to see this as a collaborative opportunity to host Dr. Marcel Yotebeing by virtually for this first time, but then hopefully in the future we'll get him to our beautiful campus and have a chance to deepen and extend our collaborative work in the Democratic Republic of Congo as well as in Rwanda. And with that, Dr. Marcel Yotebeing, welcome virtually to Michigan State University, to the African Studies Center, and to the Neuropsychiatric Research Program in the Department of Psychiatry.
Thank you very much, Michael. My video is off. I need to share my screen too.
I'm just going to mention, we're going to, any questions that you have during the course of the presentation, please enter into the Q&A and or hold on to those, and then Isaac will be fielding your questions at the end. We will reserve ample question time at the end.
So before I start, please allow me to actually express my profound gratitude to Dr. Michael Boyven for the opportunity and the invitation to Eye on Africa and the Department of Psychology team for organizing and putting together this talk, and all of you here to have taken your time to attend this. I'm not going back too much on the introduction that Michael have said, but I just want to say that within one of the major grants that I'm a PI on it, which is the International Epidemiologic Database to Evaluate AIDS, that I will be referring some publication from it here. We do have operation in Cameroon, the Republic of Congo, the Democratic Republic of Congo, Burundi, and Rwanda as well. And that's some of the, I'll refer all of this, I'll refer a lot in the data from the IDEA, International Epidemiologic Database to Evaluate AIDS. So each time I say IDEA, that's what I'm talking about. during the thing. And despite the missed opportunity to visit your beautiful campus, I hope COVID nightmare will be short-lived and that I will have another opportunity to not only visit the campus, but to meet you all in person, either on campus or somewhere else. I do not have a conflict to declare. In light of with Eye on Africa objective, my goal here is really to provide you with highly contextualized knowledge about universal healthcare in Africa. At the end of this presentation, I hope you will be able to explain the historical forces that shape the current healthcare delivery system in Africa. And talking about psychology, I will not get too much into it, but once I will explain to you the universal coverage, which means that people should have access to psychological care if they need it, you'll quickly see how each of you, whatever you do, whether you are in agriculture or everything, have a role to play in actually the betterment of the well-being of people, not just because not just because it's a moral issue for us, but also because it's an economical issue, because we usually doesn't see this as an economical issue that affects us, even as far as we are in the United States. A sustained growth in Africa would benefit us individually and as a country. I hope you will be able to explain how health as a right become the priority of international development and summarize progress, challenge, and opportunity in reaching universal health coverage in Africa, in Sub-Saharan Africa. I'm focusing in Sub-Saharan Africa in particular. So what is universal health coverage? I will start by defining that and then reviewing the landmark. This is the outline, reviewing the landmark decision and event that brought the world to the current consensus that ensuring healthy life and promoting well-being at all ages is essential to sustainable development. I will then discuss the progress towards this goal in Africa. Using HIV as a prime example, I use HIV because that's my focus area. But you could pick mental health, you could pick any other thing to use as an example. But HIV is also a very good example because of as I will show to you, because of the international funding and commitment that have gone through. So to show what we are capable as international community, as humanity to do when we commit to do something. And the challenge, discuss the challenge as opportunity, particularly with regard to the quality of service. I will end by using the framework developed by the National Academy of Science Committee on improving the quality of health to discuss how to embed quality in the current effort to scale up health services on the continent. What is universal health coverage? The WHO defined it as ensuring that all people have access to needed health services, including prevention, promotion, treatment, rehabilitation, and palliation of sufficient quality to be effective. This is actually very important, the sufficient quality to be effective, not just access, while also ensuring that the use of these services does not expose the user to financial hardship, which once many of us here, by using this definition, can conclude that the United States is not yet there before we don't even need to discuss. So this is something of a process that we need to get there, and you don't get there and sit there and forever. It's a dynamic situation. The universal health coverage actually have three interrelated objectives, which is equity in access to services, meaning those who need the service, the services should get them, not only those who can pay for them, that the quality of health service is good enough to improve the health of those receiving it, and financial risk protection, ensuring that the cost of using care does not put people at risk of financial hardship. Really, the idea that everyone will that everyone who needs health services should get them, and of sufficient quality is a revolutionary concept. Margaret Chan, the former WHO director, who was the director when these things were being debated, described it as the single most powerful concept that public health has to offer. The journal Lancet in 2012 described as the third global health transition, obviously after the demographic transition that began in the late 18th century and changed the world in the 20th century through public health improvement, including basic sewage and sanitation, which have greatly reduced prematurity, particularly in the Western world before the advent of current so-called modern medicine. The epidemiologic transition that began in the 20th century, through which communicable diseases from smallpox to poliomyelitis has been eradicated or controlled on a scale never imagined before. But how do we get to the idea that this is going to, that everyone who needs health services should go get it? It has been a very long road. And because throughout the human history, access to health service has been a privilege reserved to those who could afford it. The first attempt to formalize the concept of universal health coverage as a global policy only go back to the post-war, the UN Declaration of Human Rights in 1948, which in its Article 25 stated that everyone has the right to a standard of living that is adequate for health and well-being of himself and his family, including medical care, and the right to security in the event of sickness. However, during the post-war reconstruction, many countries, at the exception in the West, many Western countries, at the exception of the United States, took the necessary step to provide universal health coverage to their citizens. But in low and middle income countries, particularly those still under the bondage of colonization in Africa, the inequity to access was rather expanding, with a small number of hospitals that serve mainly the European and a few local elite, while consuming the majority, the lion's share of the public health budget in those countries. Following the wave of independence of African countries in the 1960s and 70s, effort to expand quality health services to a greater number of African was initiated. But the global and first coordinated major push to universal health coverage or to universal access to basic care will not come until the end of the 1970s, when at the 1978 WHO conference on primary health care in the capital of what was then the capital of actual Kazakhstan, Almaty, participants declared that government have a responsibility for the health of their people, which can be fulfilled only by the provision of adequate health and small social measures. The resolution also states that a main social target for government, international organization, and the whole world community in the coming decade, the decade after 78, should be to attain the attainment by all people of the world by the year 2002, by the year 2000, level of health that will permit them to lead a socially and economically productive life. This was the slogan of this was health for all by the year 2000. But finally, the resolution from the Almaty conference identified primary health care as the key to attaining this target. But This was very criticized at the time, and rightly so, for being too broad, idealistic, and having an unrealistic timetable, the year 2000. Another common criticism was that the slogan was not feasible. Health for all by 2000 was not feasible. Conscious of this criticism and concerned about the identification of the most cost-effective health strategy, the Rockefeller Foundation sponsored in '79 a small conference entitled Health and Population in Development at its Bellagio Conference Center in Italy to specify the goal of primary health care and to achieve more effective strategy. The result of the Bellagio Conference was the introduction of what was then called selective primary health care, the idea of obtaining low-cost solution to very specific and common cause of death. Selective primary health care had explicit area of focus that were believed to be the most important. Those important areas were known as GOBI, or growth monitoring, oral rehydration treatment, breastfeeding, and immunization. And later, GOBI FFF, adding food supplementation, female literacy, and family planning. These aspects were very specific and concise, making global health as successful and attainable as possible. But the idea of health as an investment, rather than just a social service that the government needs to pay for, will not come despite the success of selective primary health care, will not come till the 1993, when in its annual report titled Investment in Health, the World Bank will emphasize the idea that actually investing in health is actually an investment rather than just an expenditure. The report will recommend that a limited package of health measures and essential clinical intervention is a top priority for government to finance, and that some government may wish, after covering that minimum, for everyone to define their national essential package more broadly. This is really, I'm giving this history to, as you will see that when I get to the deeper thing, to see what are the forces that shape the health system in Africa, because most of this is how the health system in Africa post-independence was defined, focusing on those selective primary health services that was scaled up. And part of those primary health services, things like chronic health condition wasn't part of it, as you may be seeing already by now. Then come the Millennium Development Goal, which was the real commitment to accelerate implementation of the limited package of public health measure, which was adopted in September 2000 by UN member states, and which included 3 direct health goals: to eradicate child mortality, to improve maternal health, and combat HIV, malaria, and other diseases. Again, focusing on the core, a small core of diseases or conditions that at the time was very responsible for a huge part of the DALYs in the continent. Following the Millennium Development Declaration, the WHO put on a commission on macroeconomy, and that commission published its report in 2001, titled "Macroeconomic and Health: Investing in Health for Economic Development." This comes in the recognition that without money to back it, Millennium Development Goal was destined to be an empty promise, a promise as Health for All in 2000. So the report have a simple message: invest sustainably in health and economic development will follow. And this comes from the observation in the report by the Commission that a 10% improvement in life expectancy at birth is associated with annual economic growth increase of 0.3 to 0.4. And following that, they also observed that in high prevalence area, in area of high prevalence of disease like HIV and malaria, this costs up to 1% of GDP growth per year to those countries. So they recommend, among other, that developing countries should strive for universal coverage of essential health service to tackle communicable diseases, nutrition, and maternal health, things that that at the time significantly affect life expectancy. That donors should increase international development assistance to low-income countries by 27 billion per year in 2007 and 38 billion per year by 2015. It's not surprised to tell you that we haven't reached that 38 billion even by into year 2020. The international community should establish the global fund to fight AIDS, tuberculosis, and malaria, and the Global Health Research Fund. And that international drug industry should provide essential drug to low income at the lowest viable commercial price. This was the catalytic of what will happen at the turn of the millennium, as the Global Fund will be set up in 2002. The Global Fund when each time I say Global Fund, I'm talking about the Global Fund to fight AIDS, tuberculosis, and malaria. So it was launched in 2002, and despite the difficult funding environment, has been instrumental in the recent gain in the fight against those three diseases, particularly on the continent of Africa. As you can see on this graph, this is their funding investment for year 2018 to 2000. 75 of the fund go to the sub-Saharan Africa. 3/4 of their funding virtually go to sub-Saharan Africa. So it have been a major catalytic forces behind the improvement in those three main killers on the continent. Along with this, and following the recommendation from the Commission, in 2003, under the leadership of President Bush, and with a strong bipartisan support from Congress, the U.S. President Emergency Plan for AIDS Relief, known as PEPFAR, was launched. And over the past 13 years, through PEPFAR, the U.S. has invested some $85 billion in the fight against HIV, the largest commitment by any nation to address a single disease in history, saving more than 18 million lives and preventing millions of HIV infections across 50 countries globally, but most of it in sub-Saharan Africa, as you can imagine. But moving on to how do we to get to this idea of making universal healthcare coverage, the center stage of international development priority in 2012, motivated by the progress brought about by the Millennium Development Goal Agenda, the United Nations Conference on Sustainable Development in Rio de Janeiro in Brazil, member states decided to launch a process to develop. The United Nations member state decided to launch a process to develop a set of sustainable development goals, which will build upon the Millennium Development Goal and converge with post-2015 development agenda. The resolution from the conference, titled "The Future We Want," included the following. We recognize that health is a precondition for an outcome indicator of all 3 dimensions of sustainable development. So this is a major statement coming from the United Nations, all United Nations member states, recognizing health as a precondition for human development. We understand the goal of sustainable development can only be achieved in the absence of a high prevalence of debilitating condition, debilitating communicable and non-communicable diseases. This major commitment from member states will lead to the Sustainable Development Goal. This is in the preparation of Sustainable Development Goal that become the post-20, that make the post-2015 agenda. So building on the advances of the Millennium Development Goal, the United Nations member in 2015 effectively adopted the Sustainable Development Goal that include an explicit commitment to achieve universal health coverage by 2030. The goal number 3, ensuring healthy life and promoting well-being for all at all age, with a specific target to achieve the target 3.8, to achieve universal health coverage by 2030, obviously. So the timeline here is here, and the target 3.3 also is to end the epidemic of AIDS, tuberculosis, malaria, and and neglected tropical diseases by 3.8, which make HIV or tuberculosis or malaria a very good example to assess the progress towards the universal coverage, particularly on a continent like Africa, where over 2/3 of people living with HIV worldwide reside. So what is the progress? What are the progress we have made on the continent or on the subcontinent regarding the universal health coverage? There is no consensus on indicator or on how to measure or monitor universal health coverage. The WHO has developed a universal health coverage service coverage index, but it heavily focuses on infectious disease as well as on reproductive, neonatal, maternal, and child health, despite the recognition that advances toward universal health coverage also require provision of non-communicable diseases like mental health, obviously, and delivering intervention to a broader range of population age group. For its 2020 global burden of disease estimate, the IHMA in Washington, Seattle, developed a UHC effective coverage. When I say UHC, I'm just talking about universal health care. Effective coverage, an index that uses 23 indicators to capture how well country align with health services, align health services with the need of the population, and how well or poorly those services contribute to people's health. This map from their recent publication in August in Lancet, last August in Lancet, this map showed the global distribution of the UHC effective coverage index in 2019. The dark red color show country with the lowest effective coverage, while the dark blue show those with the highest coverage. Obviously, United States is not among those with the highest UHC coverage, but Sub-Saharan Africa as a region had the lowest. The dark red or the red have the lowest and was among the widest range of UHC effective coverage performance in 2018, with 2 countries ranking in the 6th decile. So having a score between 16 and 70% of the index, which is Rwanda and South Africa, and 11 countries, mainly in Western and Central Africa, and Angola, Nigeria, Niger, Mali, Chad, with the first quartile having the lowest, the lowest actually on this end, that is Central African Republic, which is on that thing. However, despite the overall low effective coverage in the region, it is important to note that gains in USC effective coverage in Sub-Saharan Africa have accelerated since 2010. As you can see on this graph at the bottom, they have the largest annualized rate of change in the 2010, from 2010 to 2019, compared to other regions, nearly doubling average annual improvement between 2010 compared to 1990 and 2010. So the period of evaluation of the Millennium Development Goal. This acceleration is driven mainly by effort to increase access to HIV, malaria, and tuberculosis services, driven by investment from Global Fund and PEPFAR. That I just mentioned to you. And speaking specifically about HIV, between 1990 and 2000, AIDS appeared to be unstoppable. For those who work in Africa, like Michael, and so who have been on the continent for a while, AIDS appeared to be unstoppable in Sub-Saharan Africa. In many countries, it's devastated an entire generation, cutting life expectancy in many Southern African countries to level prior to independence. But starting in early 2000, with funding support from Global Fund, as I just mentioned, and PEPFAR, mainly from those two sources of funding, and technical guidance from the WHO put down regular update of guideline of how to manage the HIV in low and middle income setting. Many African countries began to turn the tide. Using data from the global burden of disease, we show that the global death from HIV peaked in 2006 from HIV, peak in 2006 and have declined since, declines from roughly 2 million deaths in 2006 to about 1 million in 2017. Currently, it's about 0.7 million deaths annually last year, 2019. Motivated by this progress, ending the AIDS epidemic by 2030 was set as a target 3.3 of the Sustainable Development Goal. To meet this ambitious goal, the WHO and UNAIDS determined that it will require that by 2020, so by next December, 90% of people living with HIV know their HIV status, that 90% of those who know their HIV status be on antiretroviral therapy, the drug that is used, the combination of drug that is used to treat HIV, and 90% of those who know their HIV should be virologically suppressed, measure of effectiveness of the treatment. So this is known as the 1919 target. This graph shows progress towards that 1990 target. At the end of 2019, the data is from the UNAIDS, the Joint United Nations Program for AIDS. At the end of 2019, about 80% of people living with HIV know their HIV status, and similar percentage of those who know their HIV status were on antiretroviral therapy, and 88% of those on antiretroviral therapy were virologically suppressed. And you can see how it's continuously increasing from 2015 to 2019. Although the progress was a little bit faster prior to those dates, but this is measuring from the time of Sustainable Development Goal, the 2015 to 2030. But we have missed the target. Obviously, we are not going to reach the target of the 1990. And in addition, despite that, the progress also have not been uniform. As you can see on this graph, ART coverage varies substantially across region, country, and gender. Country with PEPFAR support, Southern and Eastern African country have higher coverage. Women have higher coverage, and country with PEPFAR support have substantially better coverage and better access than country without. Even within country, this is an analysis I don't show here, but it's data that we have published. We published recently in the Journal of International AIDS Society. Even within country, within the same country or within the same city, clinics that have PEPFAR support achieve better outcome than those without, which highlight the importance of funding and actually sustained funding in achieving the required target outcome. Which brings me to start talking about the challenges and opportunity. And as I highlight the importance of funding, it's important to note that despite the bipartisan support in Congress and commitment across 3 US presidents, President Bush, President Obama, and now President Trump, PEPFAR funding levels have remained flat since 2008, around 6.5 billion annually. Although the number of patients or individual, because the yellow bar here show people who have benefited from which through PEPFAR funding have received voluntary medical male circumcision, and the bar in blue, those who are currently on antiretroviral treatment. So even though the number of people continuously receiving care continuously increase, the funding remained flat. So that's really a major challenge. And in addition, with the current level of, in addition that the funding is remaining flat, the current level of coverage has not translated in the expected level of effectiveness. We are still quite far from the 72% viral suppression level in the population. As a consequence, close to 700,000 people deaths still occur annually. I mentioned this before from AIDS. Mainly those deaths are in sub-Saharan Africa, and some demographic group, including adolescents, have not experienced any decline in mortality, which indicate a serious problem in the quality of care they are receiving, because we actually have the tool, they have access to to the services. Why are they not seeing the benefit? Why is the service not effective? And in this analysis from the IMH, the Global Burden of Disease, looking with the UFC Effective Coverage Index, the issue of poor quality, it showed that the issue of poor quality results in gross inefficiency at the time, particularly when funding is declining or flat. This growth showed the USC Effectiveness Index by log transform pool health expenditure by country. The line represents the expected USC Effectiveness Index at a given per capita expenditure. So if you are like Somalia, who spend virtually nothing, you should be getting an effectiveness index per this line somewhere around 30, 38 or 37%. And if you are United States, who spend about 8,000 for this line, you should be way up here. So the African countries, sub-Saharan African countries are mostly in orange or yellow, depending how you see them. Dot in this, mostly as expected cluster here in the bottom quarter left of the graph. But you can see that despite their low investment, per capita investment, there is a lot of variation and a lot of inefficiency. You can see countries that are extremely low here. Rwanda won't appear with a very good student fall exactly on the line. So they are where they should be expected given the amount of money they spend on health. They are exactly there. But except for Rwanda, no other African country is above the line or on the line, which is show that there is a lot of efficiency that could be gained with the current investment being made if we improve quality. And this problem of quality is obvious. It's an obvious problem and a global concern because it's a large problem. It's not just in HIV, it's in all sectors. And in 2017, the National Academy set a committee on improving healthcare quality with the task of assessing how do we improve healthcare quality. I was honored to be part of this committee. The World Bank and Lancet have their own committee and publish their own report. The final consensus report coming from our committee concluded that while the tremendous gain made against the burden of illness, injury, and diseases and disability in recent years warrants celebration, this gain and the new commitment to universal health coverage are not sufficient to close the enormous gap that remain between what is achievable in human health and where the global health stands today. So between what Somalia can achieve with their maybe $1 or $2 expenses per year on per capita, on that graph that I just showed you, you saw that even with that, they can still gain a lot from that investment. It further states that even if the movement towards universal health care succeed, billions of people will have access to care of such low quality that we will not help them and indeed often will harm them. And that without a deliberate and comprehensive effort to improve the quality of healthcare services globally, UHC, universal health coverage, will too often prove to be an empty vessel. This is quite an indictment on the global priority. And this indictment did not come lightly. It came in light of the result of the analysis that was done for the report and showing that between 5 to 8 million deaths globally annually, we have about 55 million deaths annually. So between 10 to 12 or 15% of those deaths can be attributable to poor quality. And focusing on HIV in particular, as you can see on this graph at the far left of the graph, that is the HIV. I don't know how much you can see it. And in red is what are in blue is what the total number of the death for that year. This analysis was done for 2015, and half of those infection of those deaths are actually due to poor quality, a quality related death. Almost 49% of those things. So, and you could expand that to other area, neonatal death and maternal death. You see that there is a lot of part or to trauma or heart failure. You see that a lot of it are due to poor quality of health and not just a problem of access in terms of it relatively. Why is care so ineffective, particularly in sub-Saharan Africa? The primary reason behind is the staggering number of deaths due to poor quality if you just pick HIV. If you just only pick HIV, can be attributed to two major causes: the weak and fragmented health care delivery system, and the double burden of disease. I will explain it as we go. Let's start with the fragmented health system. This graph shows you roughly what the health system is. If you look at the center, which is primary care, take that primary care as the HIV, as an HIV clinic. If you are an HIV patient receiving your care in that HIV clinic, if you need any other services, if you need mental health, if you have developed tuberculosis, which a quarter to a third of patients dying of HIV will die from tuberculosis. If you develop tuberculosis, if you have diabetes, if you are pregnant, you have to get out of the clinic to go seek services in another clinic, and sometimes in a different health facility, not even in the same facility. So, and those clinics, because they were set up to manage acute diseases, maternal and child health disease, malaria, and so on, they don't communicate together. They don't always have a patient file. And so once you go to that TB clinic, the patient there who is treating you, the provider there may not even know you have HIV. And even if they know that you have HIV, they may not know what to do with it. So the result is really that your care is interrupted and obviously of not of a very good quality because it's not coordinated. And this is not just a statement. In our analysis of mortality within the international epidemiologic databases, this is a global analysis. IDEA collect data from 144 countries and 146 clinics. I may be slightly off on some of those things across the globe, except on all continents except Europe. So when we look at this data recently, this analysis was done actually to inform the United Nations, the UNAIDS estimate on mortality. What we realize is that 57% of deaths on antiretroviral in sub-Saharan Africa actually occur after loss to follow-up. And that loss to follow-up may just be that the patient went to the TB clinic. At the level of the clinic, HIV clinic, that patient, we will not know where the patient is, and we will mark it as loss to follow-up. And that this proportion is increasing from 41% in the period of 2001-2006 to 75% in 2015-2017. 2017 is when we closed the database for this analysis. So you can see 77% of deaths that occur on antiretroviral currently are occurring after the patient is no longer in the HIV clinic. But this patient is being counted as have been started antiretroviral, which is true. They started an antiretroviral, but they may have needed other care and just left the clinic. And when they go there, nobody knows what to do. And the result is catastrophic. The second point is the weak health system that I mentioned is the weak health delivery system. Remember, the healthcare system in sub-Saharan Africa was set to deliver selected primary healthcare services, not to develop, not to sustain, to provide chronic healthcare like HIV. And good services delivery has at least two components: the availability of services and the readiness to provide the service. Service availability depends on the distribution of facility and a trained health workforces. Service readiness depends on the presence of basic amenity such as reliable power, improved water sanitation, standard infection precaution, and medical equipment. But a facility survey has demonstrated over time, stockout of ARV is a serious barrier of ending the HIV epidemic. You can see on this graph, this is the data from regular survey of facility in South Africa, one of the best performing health systems on the continent from the data I just showed to you, and done by MSF. They do it annually. And this is the data from 2015. And you can see that they show you the proportion of clinic with some stock out of antiretroviral and the or TB medicine. And you can see the proportion is increasing. If you look at the total here, the proportion is increasing year after year. As the number of patients obviously in clinic are also increasing. Those clinics are very frequently running out of medication to treat this patient, which is a weakness of the health system. And this is not just a problem. If you can imagine that in weaker system, like in the Democratic Republic of Congo, the same survey conducted by the same organization, MFF, this publication behind from in +1, is from that. The situation is even worse because those countries do not actually have a lot of internal resources and do not have a well-organized system. And the shortage is really a major barrier to care. The third problem I mentioned is the double burden of disease. In addition to the weak and fragmented healthcare system, Sub-Saharan Africa also faced something that no other region has faced before, the double burden of disease. As you can see from this graph, on this graph from the IHME global burden of diseases, cardiovascular disease are now the second cause of death in the region, and actually the first cause of death among people 30 years and older in Sub-Saharan Africa. But because non-communicable disease was not part of the primary healthcare package before, those services are hardly available. And this is a study to show you how much those services are not available, and when they are available, they are such a poor quality. This is a survey of on hypertension among HIV-infected patients being enrolled in our international epidemiologic database in Cameroon. We found that though up to the quarter of patients, this is a sample of roughly 9,500 patients, over 2,000 of them, 25% of them actually had hypertension at the time of enrollment. And 99% of them were not on any antihypertensive medicine. And of the 28, 1% on medication, only 6 have control their blood pressure under control. Those clinics are really not a typical clinic in the country. These are large, usually well-staffed and well-set clinics. These are actually in Cameroon. We are only in the regional reference hospital that those clinics are based. We only get data from regional hospital, not that we refuse all that data, but this is where our data come from. And from that level, you can see how just something simple as blood pressure is not really controlled. Patients do not have access to it. If you took another component like mental health, this is a study in from our IDEA site in the Republic of Congo, Brazzaville and Pointe-Noire. The clinic are the largest clinic in Brazzaville and Pointe-Noire, and those two clinics account for 50% of HIV patients on medication in the country. In this study that we conducted among adolescents who were receiving care at those sites, we find that 39% of them have depressive symptoms, and that those with depressive symptoms were about twice as likely to be not adherent compared to their peer with no depressive symptom. Remember, I told you that this group of adolescents have not benefited from the scale-up of HIV services. And do those patients have access to treatment? When we survey the IDEA sites globally, we find that the management of depression was available in just about 40 sites. Remember, when we say available, this may be that at this large hospital, there is a psychiatric service, which is part of that hospital. Therefore, we say that the management is available. So even when we say this is available, it's not really available to the patient. It's just roughly that physically if you can refer a patient at the walking distance to these services or in the same service, but access is not necessarily free to those patients. So, which is not really meaning that it's available. So how do we go by to save those lives and improve quality? If you are particularly interested in HIV, I would like to point you to this consensus statement on research priority to inform, treat, or implementation for people living with HIV in Sub-Saharan Africa that we led as part of the 2018 IDA Africa regional meeting. You can switch HIV in this thing and put hypertension, tuberculosis, malaria. This is just an example. So you can still read those things and you will see the same thing will apply for mental health or any other services. To inform this consensus, we also do a lot, we committed a lot of review that was published in a supplemental issue of the Journal of Virus Eradication. I have listed some of those, the title from those review here, but they are not all, and as well as the WHO and the UNAIDS also wrote a viewpoint on how we collaborate and use observational data to improve this thing. You can check those papers if you are really interested in HIV, but not even if you are interested in HIV. I say many of those things will apply to. It's not specific to HIV. HIV is just an angle to look at it. Within the Committee on Improving Healthcare Quality Globally, this is the framework that this framework was adopted, and therefore the framework that National Academy of Science, Engineering, and Medicine is pushing for improving the health quality. It's really what you should focus on. It is that no matter who you are, you have a role to play. Whether you are a public, you are a provider, you are a government, you are a payer. You know, when we say payer in most of those regions, increasingly insurance is starting in the region, social insurance. For example, you have very successful experience in Rwanda. This report, actually, we went to Rwanda to cover, to study their experience, and even to the Democratic Republic of Congo to study the lack of experience. So those reports will cover, and this is what we are recommending as a framework. We recommend it as a framework, but the key point is, as the fragmented healthcare system make things extremely difficult, and as I show you with the analysis of mortality and that many patients are dying outside of the clinic, the first step is to improve the patient journey, recognizing that from the moment of conception to the moment of death, the patient will come in contact with the health system at the different interval. Their need will be different, and they will therefore require different support. So we need to organize our health system to be person-centered or community, as in the report, we say community center, knowing that the community have a role to play at it, to be, and not provider-centered, because the image of the graph that I showed to you is that if you need TB, you go to the TB provider. If you need mental health, you go to the mental health provider. We should find a way to make those services go to the patient and not put the onerous burden on the patient to go find those services and receive them. And that will be a major, that will be substantially help. And the huge opportunity in Sub-Saharan Africa is that we still have to build the chronic, the system to deliver chronic health care. So we can build this this system in a way that is really person-centered and or community-centered, how you do it. Within the committee, we also, the way to really improve the thing was recognizing that there is not a lot of study to how to do those things, that the health system, we have to adopt the learning health system model to really do this, and continuously learning, evaluating, and assessing what we are doing and analyzing it, and feedback into into our intervention. And I was lucky enough to get I'm lucky enough to receive funding from the PEPFAR, NIH, to actually do implement this or test this at a large scale in the Democratic Republic of Congo. This is the protocol that is published, and in which we have in the province, we took an entire province, the province of Kinshasa, and randomized health zone to really use the continuous quality improvement intervention to improve long-term outcome of antiretroviral in women. I focus on women and children. In women in the receiving HIV care in this area. We are about to conclude the study. The study is actually going to end next year, next May. So stay tuned for the result. And I will be happy also to discuss much more in detail of this study if you are interested in really how to improve, how to embed or test embedding quality improvement into your work as well. In conclusion, what I would say is that Africa is far behind on Sub-Saharan Africa is way far behind on providing universal health coverage. And this is the result of historical forces and coming late into the game. But they have made substantial progress, particularly starting in the year 2000 when various funding from Global Fund and PEPFAR arrived. There have been substantial progress, but those progress have been really uneven. The initial focus country of PEPFAR were only 15 countries, 13 in Sub-Saharan Africa. So you can, and as I explained, those who received those funding did very well, and those who did not receive it, including South Africa and Rwanda. I'm not saying it's the PEPFAR funding that make all of those health systems so highly performing, but they do well. They do well, and those who do not receive it have not done very well. The weak and fragmented healthcare system delivery in Sub-Saharan Africa and the double burden of disease it faces make achieving universal health coverage challenging, and the care itself very inefficient, and we all have to address that. In the face of flat and declining investment in health or funding for health, the need to embed quality in the UFC efforts in Sub-Saharan Africa is dire. And tools to improve healthcare quality exist, including adopting the learning healthcare system, which is currently being tested in randomized cluster trial. Either as a member of a public, my take-home message is that whoever you are, whether you are a member of a public, a health provider, government, health professional, or payer, all of us have a role to play to ensure that no one is left behind in the universal healthcare effort. Because, and on that note, I will end it here and take questions.
Thank you so much. That was wonderful. So please, if you have questions, you can start writing them in the Q&A section, or you can raise your hand. So we're waiting for questions.
Okay. Mike Boyven here. Can you hear me? Yeah. So while we're waiting for questions to come in, Marcel, wonderful presentation. Really appreciate all the work you've done. For those of us in psychiatry, we've often struggled with the motto that there's really no health without mental health. And your focus is on primary care with, but to what extent has global mental health really been embraced as part of the whole universal healthcare global commitment? Yeah. Or is it a whole separate battle? I mean, what's your sense being on the front lines of that global battle for universal healthcare?
The mental health, and in particular depression, because depression represents a huge burden of life with disability, and therefore account for a large amount of values particularly in Sub-Saharan Africa, but not only in South Africa, in Sub-Saharan Africa, even in the United States. And because the objective now is to look for its effectiveness, or things that improve life, the depression in particular is at the center of the universal health coverage. The challenge and the opportunity for us as a provider and healthcare and researcher and health provider and researcher. The challenge is that, as you know, on the continent, there are virtually psychiatrists are almost inexistent. So people will not tell you, even if you go to a clinic and some clinic and I give the word psychiatry to people, to nurses, they will ask you, what is that? Because they never hear of it. So there is a huge opportunity for us, and particularly a place like your group at Michigan State, who have good affinity with the African continent, to really push, to introduce, to embed the mental health in all of the system. The embrace is there because it represents a significant share of the DALYs. So the embrace is there.
Well, thank you so much, Dr. Yotebeing, for a wonderful, wonderful, rich discussion on universal health coverage that goes back, gives us a background on the history, and also analyzes what's going on currently. The questions have started pouring in, and the first one is from Kelsey Gewitz, and she asks, this is a broad question, but do sub-Saharan African countries have the expertise in-house to develop universal health coverage? What are the needs that they might have to go out of country for?
That's a extremely very good question. We just discussed mental health. And I just, in answer to Michael, mentioned that even the word psychiatry may not be recognized by some clinician, by some provider, which means that the need is commensurate to the burden of disease. So the need is tremendous. Obviously, there are a lot of model of training, and HIV have actually, from the HIV model, we have learned how we could actually accelerate, and within that context, because the task shifting, for those of you that was not, there was a trial that was published in Lancet in 2003 on how to shift. Before then, everyone was that doctor need to prescribe antiretroviral. This was a medication, and a medication with substantial side effect. Only doctors were allowed to prescribe. And there was a trial that was done in South Africa that showed that virtually the equivalence of letting nurse prescribe antiretroviral was as effective as that of the doctor. So although yes, the need is huge. And there is opportunity not only to train people, but opportunity to do research in the such a type that we can actually task shift certain work to people of lower training. Because to train a physician will require that the physician complete the 12-year of grades education, complete the 4-year of college, and the other 8-year of training. So we are actually talking about a very lengthy 24-year of training. We cannot wait for that. There is an opportunity to find out alternative way to train for those who do research in education, to find alternative way of how do we shortening all of those training to meet the demand.
Thank you very much. Yes, I think that is a very interesting question indeed. One of the things that comes up is the whole issue of African efficacy on their own, or the African economies themselves are not doing too well. So when the economies are not doing well, governments are not quite able to provide the kind of support and coverage that's needed. You mentioned chronic diseases as being left out of the game. You know, one wonders, you know, asking a broader economic, social, political question, you know, how long Africa will have to rely on foreign help.
That's a very good question. And the report on macroeconomy, on macroeconomy and health from the WHO that I just saw actually answered that question. And the Rio plus 2020 conclusion is also answered that question. Investment in health is a precondition for development. So if we don't invest to improve health in Africa, we should not expect development to happen neither. So let me give you a concrete example. A girl who is born today in Singapore is expected to live 87, 88 year to be 87 or 88 old. A girl who is born in Central Africa today is expected to live no more than 55 years old. Let's suppose we educate both those girls that we educate them and they make the average income of that country. Let's say 500 for Central Africa and let's put 20,000 for Singapore. The Central Africa is going to earn the money from, let's say they will earn the money from the age of 20 to 55. That would be 35 years of earning. They are still earning low. It's not a major problem. But the girl from Singapore is going to earn their money from the age of 20 to at least 70 years old. So they are getting not, what is it, 15 year more gain in economic output from the same investment in education we have put in. So it is normal that Central Africa will remain behind despite putting the same investment, that Singapore will continue to grow faster than Central Africa. It's up to us to recognize that thing and help Central Africa invest to make sure that this girl do not die at 55 and can work again at least up till 65. So improving the life expectancy in Central Africa will actually help us maximize on our investment and allow Central Africa to get out of the cycle of poverty that fit the cycle of violence that keep it back. So it's a precondition. It's not that we have to grow to develop before we have health.
Right. Well, that's such a graphic and very helpful example that you just gave. I have a question here from Amana Eziamama, and she asks, in thinking about sustainable universal health coverage, can you speak to strategies to incentivize nations to appropriate more of the GDP to health, particularly in sub-Saharan Africa?
The strategy to incentivize, I'm not sure I understand the question very well. But the first thing is to put the data that we are talking about. What are the major burden of disease? Because when we are talking about Sub-Saharan Africa is also heterogeneous. If you are talking about South Africa in particular, malaria is not a major issue. If you are talking about the Democratic Republic of Congo, malaria is a major issue. So those two countries may not invest in the same thing. HIV is less a burden in Democratic Republic of Congo than in South Africa. But those economic analyses that I'm talking about and health analysis, what is the burden of disease? What costs you the most life expectancy in your country? What is reducing the target? And what is the path going forward? Because if you only focus on maternal and child health thing, you gain very quickly some life expectancy, but the chronic disease will come immediately. And if you train those people and they die at 40 of a heart attack or stroke, it doesn't matter that much, right? You still have a lot of loss in the productivity. It may be not even being better that they should have died at birth, that you didn't have to invest to educate them. So it's really analyzing this data, showing it to the government, recognizing that those governments do not have the capacity, the human and capacity to do all those analyses. So help them doing those analyses, provide guidance, which the WHO now have an entire division of quality and that focus on sustainable development at where to provide those guidelines to not to motivate them. I think as a good politician, if you explain to them that investing in health is a precondition to improve, and the money to invest is there, and they don't have to go and invest in security or instability, then we can convince them to do. But that being said, African nation came together in Abuja. I think it was in 2007, and committed to invest 15% of their national budget to health. They have not met that target yet. So there is still a lot of effort on the continent to be done. But there is a lot of things that is going on as well on the continent. That we have the CDC, Africa CDC, that was set up recently, and which has shown itself to be very effective during this COVID pandemic, and to be that coordinating effort across multiple countries are actually very effective on the continent. So that's what I can say to that for that question.
Okay, thank you. We have a question from Stephen Anderson, and he says, thank you for a very informative presentation. As you mentioned, we have seen an increase in the number of countries in sub-Saharan Africa pursuing national health insurance schemes to achieve universal health coverage. You noted the success of Rwanda in this regard. My research focuses on the National Health Insurance Scheme in Ghana, which faces challenges in regards to quality of care and provider payment. Do you think national insurance schemes provide a strong avenue for achieving universal health coverage on the continent at this point, given the potential negatives associated with underfunded schemes?
That's a very good question, and I think he may be better placed to, because I'm not a health economist, he may be better placed to respond to that. But one of the things that I would say is that even in Rwanda, I mentioned that I brought the committee to Rwanda to look at the situation in Rwanda. And even in Rwanda, they struggle to make sure because for the few years, it was initially managed by the Minister of Health. The Minister of Health who do not have the technical capacity to manage an insurance, even with the very good intention and a very good leadership like him. The Minister of Health do not have that capacity. After a few years, they were running out of the money by June when it was managed by the Minister of Health. They recognized their lack of capacity and transferred it to the Social Security insurance management, which is still a government run thing. But those people actually have the capacity to manage an insurance to do the projection. And it have improved. When we visited hospital and talk about the payment, how regular the payment, the hospital testified that since they got to that level, they don't run out, their bill they start having delay in their reimbursement, sometimes starting around September, October, which means that's probably when they run out of the money. So there is a risk of not being fully funded. But the problem is really about how to set it up and set priority. Because if we set the health insurance like we have done it here in the United States, for example, if we are focusing on terminal end disease and getting the insurance to pay for dialysis or all of those expensive things, it consumes a lot of money, but the gain in terms of life expectancy is not that much important. So it's really about the country, not say important, I have to avoid that word. It's not that much. So it's really about the country, about the technician in the country to really make sure this is sustainable on the long run and make sure everyone pay and make sure health provider are well compensated. Because if we don't have compensate the health provider correctly, we know what will happen. They will leave. They will leave the health sector and go do something else. So it's not like this is not going to, so we need to really be careful about it. But that mentioned, Ghana is also actually a very good student on that in Africa. Ghana have embraced the social insurance and is doing, despite the struggle, everything we learn as we go. Even in the United States, we have not mastered the insurance yet. We still have difficulty. So despite the struggle, everything is going on, and I think we can get there. Hello?
Yes.
Yeah. Okay.
Thank you, Dr. Yotebeing. Another question here from Shuchi Kosla. Thank you for your excellent presentation. What role do you think cultural beliefs of sub-Saharan Africa play in acceptance versus interference in the way of mental health services deliverance and acceptance?
That's a very, very good question. And it's the way we say, if we provide mental health to make it to be person-centered or community-centered, which means coming from the perspective of the person who is receiving the help, it is obvious that acceptance, the problem of acceptance will be limited. Because if we pose it as explained, but if we create large psychiatric facility and lock people into it and create additional stigma around the mental health, then we are going to face the difficulty of acceptance. If we create stigma around the mental health more than what is already existing, then it's going to. And that's where we need a lot of anthropologists. We need anthropologists. We need people who understand how to manage culture. We need people who understand the local culture. We need to associate them and to do it with them, not to do it for them. This is really the most important thing to do it with them, not to do it for them. And that go back to some of the questions that we have that have been asked. How do we have the government involved? We need to do it with them. We don't have to do it for them. Even if we are bringing the money, we have to do it for them. And PEPFAR offer a very good model for that as well. And even the Global Fund. The Global Fund, the government apply for the money. The government define the plan of what they want to do. If the government of the Democratic Republic of Congo put their application in the Global Fund, it gets reviewed, but it gets reviewed for what they have proposed to do. It doesn't get reviewed for what the Global Fund want to pay for. If they didn't include TB into it, the Global Fund will not say, we have to include TB into it. They will review it and say, you want to do HIV, prove to us that you can do all of those HIV you are proposing to do. So that's a relative way I think we can do to limit the problem of acceptance and avoid being seen as a foreigner or as a foreign. When I say foreigner, it's not just from the Western to the, even coming from the capital city to a local community, you can still be seen as a foreigner because you are not from that community. So we need to be very careful about that.
Thank you for your answer. Another question here from Kelsey. How are mental health illnesses generally perceived on the continent in terms of the importance of their impact on overall health and the understanding of the need to seek help from professionals trained in the field of mental health?
Again, that's a question that I'm not really a specialist on that area, but from my experience as a provider, as somebody who grew up on the continent, I'm originally from Cameroon, and I do some study in mental health. There are two aspects of the mental health. Sometimes mental health is seen as a blessing. It's God speaking to you. And therefore, it may be the rite of passage, it be seen as a rite of passage to become a priest or something like that. So, and depending on that context, you see it's very different because I experience mental health, and when I get out of it, I become a priest. It actually gives me a very, very honorable job, a very honorable job. On the other side, mental health can be very stigmatizing. Actually, in my culture and in the village I grew up in, if you die of suicide, we don't give you dignified burial. We go and throw you and bury you in the bush, which is very, very stigmatizing. And all your family will live with that shame on them. because each time everyone asks where you were buried, you have to tell them you were buried in the bush, and nobody go to that bush to pay any respect to you. So you can see how it can be on both sides, and require really, when you approach those things, to really get anthropologists, cultural anthropologists to be involved, get people who know the locality, and it can vary. The continent is extremely diverse from one end to the other. So that's the answer I'll give to that question.
Thank you. Another question here from Judith Namanya. Thank you so much for that informative presentation. The definition of universal health coverage seems to focus more on improving the quality of healthcare service delivery and its accessibility, and not more on accessibility. What is the of affordability, that is transport fares to the health facilities, given poor roads, then the acceptability of health services, cultural norms in downplaying the much quality of health service delivery?
That's a good question. And when I was talking about and say the good service depend on availability and readiness. Availability means it's available where you are. Even if I have a free access, I'm here in New York. Even if I can come to a clinic in Michigan for free, that's not really accessible to me. It's not really available to me. So it depends how you want to see that definition. So that's really it. And quality of service that is timely. If you define the quality, that is timely, that is efficient. If it's not, if I have to spend 2 days to get to a delivery center, obviously the service will not be timely. Because when the contractions start, it doesn't give me 2 days to get to the delivery center. So acceptability is also a very, very important, because if the service is person-centered, if the service is from my perspective, it's obvious that I will accept it. I don't accept things that I don't feel respect me. If I feel things respect me and I agree with it, usually that's what you call acceptability, right? It's from my perspective, I can agree with it, I can see to it. So what you are defining actually will fall into the quality of services. And the affordability is what the financial risk protection. I didn't talk too much about the insurance and the financial risk protection, because that's something that needs to be figured out. And one of the questions of financing that come from the financing on Ghana actually address that, and I'm trying to avoid not getting too deep into it.
Okay, we have one more question here from Itzia Familia. It may be early to say, but have you been able to measure the impacts that the COVID-19 pandemic has had on service delivery and ART coverage?
I have not been able to measure directly. We have survey currently ongoing within IDEA that will give us that data. But I listened to the talk by John Kingason of the African CDC the other day, and the disruption of service have been tremendous. Obviously, within the clinic I work in over 150 clinics personally. I have research ongoing, and the disruption of services have been huge, not just at the level of the clinic, because countries shut down their border, which means that goods were not coming in. And those goods, virtually all those countries import antiretroviral from, all those countries in Sub-Saharan Africa import their antiretroviral, mostly from India. So when they shut down the border, they shut those goods outside. And there was a need to provide more antiretroviral to patients so that they don't have to come back to clinic for social distancing. If you don't have a huge supply, and you are giving out more, the problem you run out of it is very quick. So there is a huge disruption, and I don't have hard number to give to you, but those numbers will be coming soon from our group, actually.
Okay, well, that does it for the questions. Giving it back to you, Awa.
Yeah. Well, thank you so much, Marcel. That was really wonderful. Thank you for coming today. And thank you to the Department of Psychiatry for your collaboration. We appreciate it very much. And please join us next time, Thursday, noon for another Eye on Africa. Thank you, everybody. Bye.
Bye. Thank you very much. Bye.
Oh, unless, do you have something to say, Dr. Baldwin?
No, I think this is great. I think these kinds of collaborative presentations through the Eye of Africa series are at the departmental level in the medical colleges, especially we just need more and more of those. And I think Dr. Marcel Yotebeing's presentation is an outstanding case in point of how rich this collaboration can be. So thank you again, Dr. Yotebeing. Thank you.
Thank you. Thank you.
Thank you so much.
And goodbye.